Hello, I'm Robin Arnold Williams, Secretary of the Washington State Department of Social and Health Services. The film you are about to see is about adolescent chemical dependence, or addiction. Now, it's an uncomfortable topic because of the stigma associated with the word addiction. But addiction is really a chronic disease that does not discriminate across social, racial, or gender lines. Every child is exposed to it, and every child is vulnerable. When your child has a fever, you know to call the doctor. If there's trouble at school, you know to call the teacher. But when it's drugs or alcohol, the path to seek help is not as clear. Now, this film can help with that. It helps us get past the fear and the guilt, and it offers ways we can help a young person overcome this disorder, regain their lives, and restore a family. Washington State is a national leader in care for adolescents and their families. This film is another step forward, and our hope is that you will find information here that you can put to good use. If your family is in crisis, there are things you can do and there are steps you can take. So I thank you for taking the time to spend with us.
The disease is that your adolescent is taking in chemicals that affect their brain and their psyche and their body, their socialization, their development, physical and mental, emotional. It's basically taking them over.
The younger you are, when you start drinking and you start smoking or you start using these drugs, the faster it is for you to become addicted, because your body is surging when you're young with all these hormones because you're growing and you're doing all this stuff. Well, when you start taking the drugs, everything is real active in there and it's hitting your brain faster.
There's really good brain imaging research that just shows what the adolescents' brains are doing and what happens with the chemicals. And the chemicals with an adolescent brain just pretty much take over. It's like the pathways are perfectly set up.
Chemical dependency is considered a disease. It's in the DSM listed as a disease. And one thing about a disease is progressive. It can progress and it can get worse and worse.
I started using drugs when I was about 15, 16 years old. Started off with smoking weed. Then I finally got tired of smoking weed, so I started smoking crystal meth because all my friends were doing it.
You start drinking and using, it's a behavior, it's a behavior, it's a behavior, and then one day there's this invisible line where it's no longer a choice that you wake up in the morning that you want to drink and use anymore. It's almost like you have to. And you cross this line, you don't know when you crossed it, you don't know how you crossed it, you never intended to cross it.
By the time I was 10, I was actually leaving home and going and staying with some friends that were down the street, and when their parents were gone, we would decide to slip alcohol in drinks and smoke cigarettes that they had left around and stuff like that. And, by the time I was 11, I was doing it daily, slipping more alcohol in, and if they didn't want theirs, I would take theirs too, and just drinking as much as I could handle, which is actually quite a bit for an 11-year-old. And by the end of being 11, I started finding other drugs like pot and pills.
I think the police knocking on your door, the school calling you, neighbors talking to you, kids getting kicked out of school, those kind of crises that will happen in addition to, you smelling alcohol in the breath, your kid acting like a monster or somebody that you don't know in your house. That's the point in time where parents really start to get scared.
It was kind of like a group thing. We'd all, on lunch, at high school before I went to rehab my sophomore year, in the fall quarter, pretty much every day at lunch we went over and we'd get high and then go back to class for the last one. And it was kind of this whole idea of, we'd go back and we'd be like, screw it, this doesn't even matter, and we'd be relaxed and high, and the grades were suffering and all that, because it was just kind of this, this feeling of defiance.
That was not his normal personality. Oh no, his normal personality was fun, and he would laugh and he'd joke. He turned into a dark, angry, belligerent, rude You know, nobody could do anything right. He'd isolate himself, and I know that a lot of that behavior was indicative of a problem.
An adolescent who's chemically dependent is not very comfortable to get close to. They're prickly. And one of the reasons why is I'm going to try to keep you at a distance as best as I can. And if I can find where you're weak, I'm going to do that so that you don't get close to me.
Throughout the whole time, you know, I was disrespecting my family. We were always in fights. My brother barely talked to me anymore. Me and my mom were arguing every day. I lost contact with my dad for a long time because I put him through a lot.
I lost trust of all my family, my friends, everybody I loved. You know, I blew off my girlfriend, blew off my family. They tried to care for me, and I would always just disrespect them, steal from them, cheat.
Well, you know, everything's messed up anyway, so I don't care. And I'm just gonna go and rebel. And what they're really doing is calling for help.
It's multiple factors that create chemical dependency. It's some genetic predisposition. It's the environment that you grow up in. It's the opportunities that you have, and it's the temperament of each child.
It was kind of just like my way to cope with things. Like, I mean, I had all these stresses with my parents, and so it was like, it was my way to numb the feelings. And I kind of just, it started out with that, and then it was giving me friends, and it was giving me all this money and all this like popularity and, you know, this good reputation or whatever. And after a while, it just got worse, and I couldn't stop.
One thing is getting the kids to know that it's not their fault. And it's not their fault because there might be a problem in the home. And it's not their fault that things are not working in their favor all the time. And it's definitely not the parents' fault.
Parents may have some influence on the raising of their kids and the stress that the kids are under and what happens to their child in their home, but no parent, good, bad, or indifferent, causes chemical dependency.
The parents are ashamed and embarrassed about this situation. The child is too, and there's anger about it, and still the fear, and you don't know quite how to act together, so everyone is disconnected.
I get really broken parents, and I guess what I would say for the parents, don't beat yourselves up. We've all been a parent. We've all done the best we could. Right when we're parenting, yes, you can always look back and make changes, but right when you're in the heat of the matter, it's the best you can do. And you just need to keep trying to keep that child alive.
Most parents know in their gut that something's wrong, and they just need the support to know that it's okay to reach out for help. That's what keeps them from reaching out, is that shame and that guilt and that fear.
Please don't wait. If you see a problem, get on it ASAP. Get help, find treatment, find someone to talk to about this. A lot of schools have intervention specialists, and that's a good place to start.
One of the first things to determine what your child needs is you need an assessment.
Team line.
So you want to find an assessment center, somebody to do that. I think the easiest way to find out where is an assessment center is call the teen line.
What part of the state are you calling from?
They keep a comprehensive list of all treatment centers in the whole state of Washington and can tell you with one phone call 3 different treatment centers in that place.
I also have another place called CCS Recovery Center.
So that's a very, very good place to start.
It means that you can use standardized assessment tools that get beyond denial. It surprises parents and a lot of people in the community that adolescents are actually much more honest about their use than adults are, and that assessment questions, self-report assessment questions, are actually usually very accurate for adolescents. So parents often think, well, my kid is going to lie to you. There's ways of getting beyond that.
The friends who gave me pot, we started going downtown to raves on weekends.
Very nice people, very supportive, very wise. They'd seen this come by. This was not the first time they'd interviewed parents. This wasn't the first time they'd interviewed kids. They could make good assessments.
I'd go to parties and I'd drink.
And that assessment is one of the most critical parts to where an adolescent gets asked a series of questions where they can determine if they have an issue with chemical dependency.
Have you ever drank to the point?
And the more thorough the assessment, the better that clinician can let the parent know the severity of the adolescent's problem and help them make a decision about where's the best treatment or placement for that young person to go.
If they've never accessed any care, outpatient is a good place to start.
There's 3 levels of care on this level, and this is outpatient. Now, inpatient is a whole different story, because if they're not benefiting from these 3 levels of care, then the next step has to be inpatient.
We came back and sat down with him and he said, your son needs inpatient treatment. This is what he's doing. And this is how much he's doing. We couldn't believe it.
It's a moment in history that you will never want to repeat again in your life. That's basically it. And it's not going to be a pretty moment no matter how you look at it. And there's very little you're going to say while you're trying to get your child to treatment that is going to make them feel any better about it. But most children I know that went through treatment will remember their parent for hanging in there.
We're coming in with the understanding that a lot of the times the parents are done. They're done. There's no more they can give. They've exhausted vacation time. They are in the process of losing their jobs if they take off any more time to come to court. A lot of parents can't come to court because of work. They just don't have that kind of flexibility in their jobs. And that's understood up front. We ask the parents, what is it that you can give? If you can't give anything else, then we understand that. And so what we do is work to build these supports around the parents.
Kids, they're gonna get mad. They're gonna say, some kids nowadays is, you snitched on me. And it's like, they're like, okay, you're like, I'm your parent. If you want to call me a snitch, I'll be a snitch, but I'm your parent, and it's not snitching.
I was mad at a lot of people. I was mad at other people for not seeing that my parents were, as I felt at that time, probably shouldn't swear on camera, but you know what I mean? Like, that they were making some huge mistakes and that it was much more of a drug problem, or excuse me, it was much more of a family type problem than it was just, I'm this kid with, like poor respect for his parents who's trying to stick it to him and be rude.
If the disease is talking to you through your kid, they're saying, this is stupid, this is overreaction, this is way beyond what's necessary, and you as a parent need to stick with it and understand that it's going to be made really difficult, not by your kid being afraid, even though that's an issue, but by the disease. The disease is going to fight and say, I want to continue using. You're crazy, you're overreacting.
So what happens when you say, okay, this is what's true to me, and this is the way I feel about it?
Most of them are resistant on denial. They don't understand, they don't believe they have a problem. They think that they just have bad luck because they were caught with a friend or a cousin, and it was the first time I had a drink and the police stopped me. It was the first time driving. So they're in denial and pretty much resistant to come to treatment. Because I wasn't open to listen. I wasn't open to see that I had a problem. I just thought I was normal. I was experimenting. I was like everybody else. It was something all teens went through. And I just thought it was just part of growing up.
We know we have behavior problems. We know that they're probably going to treat us badly, and my staff knows that, and that's okay for us. We can sit right with them when they're really ugly and crying and screaming, and right there on the floor with them, and then be just as proud to sit there or get up with them when they graduate.
On the best of all circumstances, you want the young person to say, yes, I'm willing to do it. There's a lot of bargaining and negotiations that go on to get the kid there.
You know, I wouldn't have done it without my probation officer or someone pushing me, especially like my family.
In my head, it was terrible, and it was the worst thing they could put me through, and I didn't see why they wanted to do that to me. They're terrible people and all this stuff, but deep down I knew it was what I needed, even though I didn't want to admit it.
They will be so angry at you, so angry. But one of the things I've told other people I know, that if your child's under 18, don't dilly-dally, because you can make them go. You can make them go, and you can make them go to treatment. Where when they're 18 and older, you have to talk them into it, and when you're talking to an addicted person, you're not talking to the person and their brain. It's not functioning.
In our chemical dependency treatment system, the parent is the one that carries that consent option, not the kid. So the parent is the primary consenter for inpatient treatment. So it's not easy, but you do have the right to put your kid in treatment, kicking and screaming. And it's not involuntary treatment when you do that. It's voluntary because you as the parent are saying, I want this for my kid.
And our program started 2.5 years ago, and it's targeted to male youth, 13 to 17 years old, that come most of the time from the legal system. They have some legal involvement, and they have a probation officer, and that help them have the option to come to treatment versus going to jail, versus going to jail.
I was forced to go to treatment pretty much. That was all. You want to stay here in juvenile?
There's a drug court contract that is gone over with each, with the family, and so they can have an opportunity to ask questions, because they have to stipulate. They're actually saying to the court, I'm bringing this offense to you, and I'm saying that I did this offense to get into this program. At the same time, I'm asking you to stay the sentence. To stay the sentence at this point, stay the guilty, stay the everything. And once I am successful at graduating from this program, I'm asking that you dismiss as though it never happened. So that's the carrot.
There's been many studies done, both of youth and adult, and court-ordered treatment is successful. Kids that are forced into treatment against their will, into treatment, sometimes do as well or better than kids that go there voluntarily. You should really ask for agencies that are set up to be adolescent-specific agencies.
Adolescence is a specialty care, and people that provide chemical dependency services for adolescents should have specialty training.
Everything is individualized, which makes drug court work. It's tailored to that family, that client, based on the information that we get weekly from the advocates.
The needs of a 12-year-old are so different than the needs of a 17-year-old. Good treatment programs will do their best to provide services that are different for a 13-year-old and services that are different for the 15-year-old and different for the 17-year-old.
There's certain parts of treatment that I want everybody to go through. How they go through that will be individualized. If I have a 17-year-old, I would expect her to be able to read and write and be more mature and cognitively aware of what I'm asking. If I have a 14-year-old, I'm going to change my expectations and the way that I help them work through their issues.
At least in the last 10-15 years, we've really tried to promote gender-specific treatment. So young girls can go be with young girls, the boys can be with the boys, and they each can address their separate issues. Because sexuality is such a loaded issue with the teens, you kind of take that out of the equation.
They were like, no, we're sending you to an all-girls treatment. And the instant they said that, I was just like, what? You can't do that. And they said that I was going to get nothing but sweats.
No cussing or gang behavior. Andy?
I think at that age, with all the hormones, it would be even harder for them to focus on treatment if they have girls in the program. I think we definitely have an advantage of having a just male facility where they can concentrate on their treatment work.
you know, she was trying to influence me getting to do it.
If you have a child that doesn't have as many severe issues,
So let's talk a little bit about support networks.
it makes co-ed groups work a little bit easier because there's not these many highly volatile issues in the group. So I think as the more severe it is, the more the need for gender specific. When it's not as severe, I think people can do a pretty good job in a co-ed group.
Dual diagnosis, mental health and chemical dependency problems have been things that have been a primary focus for treatment, just nationwide.
It could be school, it could be mental health issues, it could be family issues, it could be physical health issues, it could be dental issues, it could be issues related to sexuality and reproduction that is very common for adolescents who use.
We do have a mental health therapist full-time, and we have a psychiatric nurse that comes once a week. So we have some co-current patients that have mental health issues and substance abuse issues.
I never knew how to deal with my anger. I barely found out that I have bipolar disorder, and I never knew that. And like, I got ADHD, and I never knew that either. So now I'm on some medication that keeps my anger level down and keeps my mood swings in control. Because when you use drugs for so long, you can't control your mood swings or your emotions.
We try to have training that provides a good level of care for kids and really acknowledges that your drinking and using is not the same as somebody else's because of your cultural background, because of how the family involves themselves with your drinking and using. That may be very different. How the culture views asking for help and reaching out for help is a huge barrier for some families. So we try to respond as best we can, and we have staff that have good hearts, have good intentions, and in many cases have good training to do that. So. Do you offer help based on the fact that somebody will get an instant fix, or do you offer help based on this is a process? You didn't become an addict overnight, you're not going to get into recovery overnight. But a lot of magical things happen to kids and families.
We took him down to the bottom. He went down to the Adolescent program 5 days before Christmas. That was hard on everybody, everybody. So we checked him in down there, and he spent 35 days that program.
There's 90 days in each phase, and it's phase 1, phase 2, and phase 3. And we've not yet had a person who's done it in 9 months. We've had some that's been close.
The length of the program is 90 to 120 days, depends on the patient needs. So it's between 3 and 4 months, and it can be extended if the patient needs an extension at 2 weeks at a time.
Our program is longer. It's 150 to 180 days, which scares the kids and the parents. But it's a definite length of time that gives them time to get well, because they didn't become addicts living on the street and running away overnight. It took a while for them to get here.
Kids who stay longer in treatment typically have better outcomes, and it's usually looked at about 90 days of treatment, whether that's inpatient and outpatient or all inpatient, that there's sort of a magical number that at 90 days the outcome gets better. So a lot of the treatment programs in the state of Washington have really worked hard on keeping kids into treatment longer, because they know that that kid is going to do much better.
We get a lot of clients who come in and who are not really bought into the program. And so we spend a large amount of phase 1 in engagement.
With an adolescent, the main thing between you and that young person is they got to be able to trust you. And one of the things that we've learned, and we learned that also in the research, is you have to engage, 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 and until they trust you, then you start talking to them about their issues. If you start talking to them right away about getting clean and sober, they're going to glaze over and start giving you the answers you want.
I want to say the 8th day, I think, is when I started to trust her. And a lot of it was, the other people in the room. We kind of, people would lightly open up, or slowly open up, and we all kind of got more comfortable together. There were some people who had been there longer than I had who were already talking and stuff, and I could see how they were interacting. And it wasn't a threatening type situation. They weren't trying to ram down my throat or any of the others' throats, you need to quit, you're being a bad kid. It was like, you need to quit, you're screwing up your life.
They're going to have a lot of structure. Structure equals love in treatment. Rules equal love in treatment. Kids don't like rules generally, so they're going to rebel against those. Treatment needs to be watching kids do the right things, not just watching kids do the wrong things. They need to give a kid lots of attention for their positive behaviors, and a lot of our programs are using evidence-based, cognitive-based approaches that deal with this as a disease, but also deal with the day-to-day behavior of a kid staying in a residential program or in an outpatient program.
One of the things that we have to get the kids to understand is it's a disease, it's treatable, it's not curable. A lot of youth say, that's some crap, man, that's not a disease, I'm not hearing that. We know that the first step is admitting that you're powerless over drugs and alcohol and that your life has become unmanageable.
I went to see my Renaissance and, learn how to control my emotions, how to regulate my anger, how to think in a positive way. Yeah, we used this great skills called DBT. It was pretty good. They taught us how to use our communication skills with our families and how to control our anger and how to meditate and think positive, not think negative all the time. They teach you about your wise mind and emotional mind. And it was a pretty good place there.
We want them to analyze, do a change analysis on why that happened. How was my behavior at that moment? Why I reacted that way? How this affected others? What could I have done different? What do I learn? So that they learn, okay, I had this issue. How could I have a look at it from a different perspective? So definitely skills for life, what to use out there. And the beauty of the program is that we're teaching it to the parents. At the same time, we're teaching it to the kids.
We do work on chemical dependency education. We do work on self. We do work on boundaries. We do work on communication skills. We do work on how you got here. And we do family work. All those are very intense for the kids, plus the school, the art, recreation, and the other stuff that are involved.
Parents are in a quandary, and because they need to be educated on drugs and alcohol, they are being educated as well. And so this is a foreign child to them, although it's their child. I don't know this child, and I need help with this child.
He was so angry, and I think that puts off a lot of families. And that's what they intend. That's what the addict intends by the anger, is to put you off. And you have to learn, which is what those classes were about. We had to, as parents, and why I had the girls go, is because we had to learn this off-putting behavior so we could be stronger, so we could learn how to deal with it.
But the families need to be doing work, and they need to be involved in the treatment process, they need to be getting updates, they need to feel comfortable talking to the counselor, but they may need to be doing their own work as well. They may need to get into some 12-step support groups like Al-Anon. They may need to connect with that outpatient agency to be getting education services or support services for themselves. They may need to go to those family events that they have at treatment centers.
We do a little mini family assessment and see from the parents' point of view what they need help with. And of course, as we get to know the kids, we'll hear their side. We start scheduling family sessions from the beginning. We try to get every family in here no less than once a month for one-on-one with our counselor that's a family therapist. The kids come from all over the state, so we have to work with the families and help get them here.
The best way to work with kids is when their families are involved.
We have family sessions, family educational sessions, group therapy on Saturdays. And then there's a follow-up on individual sessions, one-on-one with the family therapist. We have 2 family therapists, one in English, one in Spanish, that meets with them individually. Sometimes the patient is not involved on those sessions, it's just the family, so that they can have an open discussion with the family therapist and discuss issues that the kids had before they came in here, or how to go about disciplining their kids when they get out of treatment.
The family counseling, it kind of started out a little rough when I was on main unit because I still had a lot of anger towards my parents. And now it's gotten a lot better, and it kind of helps me to be able to communicate with my parents, because the last family counseling I had, we talked about people that I can't be around. And normally I'd get really defensive, and my mom was actually scared to bring it up because she didn't know what my reaction would be. But she was so surprised when I just sat there and I just talked to her, and I was like, no, I know I can't be around them anymore. And she started crying.
I always had to use drugs to be happy and to not have family problems. But if you have family problems, it's just part of life. That's just the way families is. You know, everybody has their family problems in their life, and now I know how to deal with them in a positive way.
Having a continuing care program is something that is, it's like a safe place where the adolescent can go out and try their skills and practice their recovery, and can have a place where they can come back and get feedback about it. How am I doing with that? These are all brand new lessons for people. And so they need somebody they can check in with, like, is that right? You know, what do you think about that? You know, what were my other choices with that? So aftercare is critical.
It set up this network of people that I could go to even after I was out. So when I was returning home, it wasn't so scary, and so that feeling of being alone wasn't there, because I had a whole, you know, like I said, a whole network.
Each patient that comes to our facility, before they graduate, we set up outpatient. So definitely treatment doesn't end when they finish the program. I tell the parents when their kid graduates, yesterday we had a graduation, and I told the parents, this is not the end of it, this is the beginning. This is just the beginning. He learned the tools, he was in a protected environment where, yes, most of the patients are going to behave, you know, because they're around people that understand their issues, but when they graduate is when everything starts. So that's when they need most of their support.
So I actually have IOP 3 days a week, and then drug court once a week, and then still going to AA and NA meetings and doing stuff that I really need to do.
Some of the things that are in the aftercare plan is just making sure that they still have continued support. And relapse prevention is something that's very important, because they're going to come out of inpatient and they're going to have 30 days sober, 60 days sober, and getting them to understand what a relapse is. What are the triggers for relapse? What are some of the cues that make people want to go back to using? And that's something that needs to be closely monitored and watched while they go back to their aftercare plan.
If your child is truly chemically dependent, they have what's called a chronic disorder, which means it's not going to go away. So they're going to have some episodes of treatment. They're going to have an inpatient stay, an outpatient stay. And then continuing care is about ongoing maintenance to make sure that when that child has some trouble, that there's help there to keep them focused and motivated and on track. And for an adolescent, there's not a straight path from this side of treatment to over here in recovery.
While in the process of phases, we realize that you're going to have relapses, because that's a part of recovery. And so we explain to them that that's not an opportunity for you to, you know, wallow and get down on yourself, but understand that we understand that you're in a process and we're here to help you.
I was sent to treatment. I was sent to Sundown, which was a 28-day treatment program where I stayed for 70 days because I was kicked out of the recovery house. And after I graduated, October 8th, November 3rd, I relapsed again. And I was getting back into hanging out with old people, faking UAs, getting diluted UAs. So I was going back to juvie, in and out of juvie.
A year and a half ago, I went to this treatment center called Daybreak, and I did good there and everything. Just that one day I got mad at somebody there, and I left. Then went to jail, juvenile. Then went back to the treatment center and got graduated, got out, got mad at my family. Didn't know how to control my emotions, to control my family anger, so I went out and used again.
I talk to families all the time that are on their third or fourth treatment, and they'll tell me that this time the kid really wants it for themselves. Were those other treatments a waste? No, because they got them to that point. They may have kept the kid alive enough to get to the point of wanting help. They may know what they need to do. They finally get more mature about what they need to do for themselves.
You're not perfect. We understand. I mean, nobody's perfect. Your parents have probably made decisions that they're not proud of. I mean, I've made decisions I'm not proud of, and etc. So just getting them to understand that it's not their fault if they relapse, and giving them the tools for being equipped. So next time they come to a situation where if there's a relapse that's going to occur, just understanding how can I cope without using drugs and alcohol. That's one of the main things, just being able to cope without using drugs and alcohol and finding alternatives. Alternatives is a key word.
You're getting ready to learn about a disease that your child may have, that at 90 days, you're still going to be a novice at best. So this is going to be complicated. It's going to break your heart a few times, but be persistent and be the best advocate you can, and don't give up. You're going to feel like giving up 50 times, maybe even in one day. Don't, because your kid needs you.
And one thing that your kid will always come back to you and say is thank you. When they get out of that stage of development and being curious and being into different things, they will come back and they will say thank you. You were a good parent, and I know that you weren't snitching on me. You were looking for my best. You were out for my best interest.
Wonderful thing is that you really get to see under all this drug, alcohol stuff, under all of the offenses that have been committed, you just have to see them be a kid. They are very much, you get to see the kid again.
I'm okay with who I am, so that's a big thing that came out of it.
It's humbling and enlightening, but there's really a wonderful silver lining out of it, is that we are a nice, healthy family. He's in school, the girls are doing well, I'm doing well, and this type of thing can tear families apart.
We all are ourselves now. We're not the drug, because before I was just the drug, you know, I was just exactly what the alcohol wanted me to be. But now I'm actually Nicole now, and I'm actually a friend now, and a daughter and a sister. And
try everything you can. Never give up, because, you know, once you give up, there's no point of even trying to help them, because, you know, my parents never gave up for a long time. They tried to give me treatment center for 4 or 5 years, you know. So I think all they could do is just push and don't give up.
Finally paid off.
Yeah, it finally paid off for me. It could pay off for anybody else.